Good afternoon, ladies and gentlemen. I would like to welcome you to our symposium entitled Research Capacity Strengthening in Low and Middle Class Income. My name is Volker Termöhlen. I'm a chairperson together with Jo Moffat. She's sitting next to me. And my background is I'm a pediatrician by training, then became a virologist, and at the moment I am the co-chair of the Inter-Academy panel, the Global Network of Science Academy. And in this capacity, I'm probably sitting here to chair. Now, if you look back yesterday and today, the word capacity building for research has probably been mentioned in every symposium and any workshop. And if you look back last night when we had the ceremony, every politician or the representatives of the industry and scientists, everybody was talking about it. And even our politicians, were giving us some sort of agenda, what they want to do. I was overwhelmed to hear what the German ministries are planning to do. I was overwhelmed to hear what Barroso was telling us. My experience in life is that if we come back to reality, it is always less what is promised to us. So anyway, I think we should not be negative about it. We should be positive. It is good that politician takes up this and that science is heard and that science is really a voice which is taken seriously in our time, since almost 80% of all decisions made, for example, in the European Parliament, is based on a science basis. And so science has a responsibility to inform politics. Now, the topic, of course, is of interest to academies as well. And the Inter-Academy Medical Panel, which is an association of worldwide academies interested in medicine, either as science academies with a strong medical arm or with academies which are purely medicine, have a couple of months ago published a statement with the title, A Call for Action to Strengthen Health Research Capacity in Low and Middle Countries. And they have taken up now the topic. In this statement, the topic is analyzed and recommendations are given to society and politics as well as to academies. And this actually statement is a statement which will be also discussed here. And Jo Moffat, she is the one who will give the first presentation and will discuss this statement with you. And I would like just to introduce her. She is a well-known colleague and scientist. She is president of the New York Academy of Medicine. She's a member of the Institute of Medicine, the Institute of Medicine in the United States, and Foreign Secretary. She has great experience in the area of global health. She has been associated with the Executive Committee of WHO. She has served in many groups and activities to give her advice, and her background is a pediatrician, and she is a clinical professor of pediatrics at the New York University Medical School. Jo, we are looking forward to your presentation.
Thank you, Volker, and good afternoon, everyone. I have the pleasure of giving you an overview of the IAMP Research Capacity Building Statement and then introducing our distinguished panel who will be discussing it with you. If I can, let's see. Sorry. Here we go. Okay. Now I just push this? Yeah. Okay, fine, thanks. First of all, as Volker said, the Inter-Academy Medical Panel is a global network of academies of medicine and science committed to improving health worldwide. We've articulated this mission and these goals, and it was established in May of 2000 by a founding resolution of the Conference of Scientific Academies, and it seeks to really create and support strong and vibrant academies and regional networks of academies worldwide. And it's unique, we think, and exclusive in its focus on human health. There are 72 members and representing all of the WHO regions, and IAMP works in collaboration with its Academy members. We are a member of the M8 Alliance, which is the sponsor of this meeting, and one of the number of activities that the IAMP does in concert with its members is the development of important statements on critical global health problems. Some are generated by our own members and members of the executive committee. Others are by other global networks of science academies. And we also take a look every year at G8 and G20, G-Science statements, and if we feel that they need to be brought to the attention of our members and to coalesce our members around pushing the issue further, we also take them forward. Once the statement is finalized, we circulate it to each of our Academy members, and they sign on. When a majority of the members approve the statement, it's issued as an IAMP statement, and each Academy underlining it is listed individually. This is the governance of the IAMP, our co-chairs, Detlef Ganten from Germany and Laimeng Louis, and you see the representation from low and middle-income countries and high-income countries, and the World Academy of Sciences is also an ex officio member of the Academy. In May of 2013, we issued a statement on research capacity building, and a working group was had been formed about a year earlier, consisting of these individuals, 3 of whom I'll introduce shortly, so you'll have a chance to meet them. And the group worked very diligently after having been appointed, and virtually and effectively, I think. I'm going to tell you just briefly about the background on the issue of research capacity strengthening, the current situation as we saw it, why we felt it was important for the Inter-Academy Medical Panel to bring it to the attention of academies and to motivate action, and then a brief review of the recommendations. The background of the report came out of the 1990, actually, report on the Commission on Health Research for Development, which identified the fact that 90% of global research investments are addressing the needs of 10% of the world's population. This became known as the 90-10 gap, and it really identified the issue of research capacity, what were the elements in it, and we feel that in order to have, to strengthen research capacity, countries need to have the ability to conduct research, synthesize the findings, manage the transition of that research into public view, public awareness, policy awareness, and the use, obviously, from bench to bedside to curbside, so that the research can be applied. And key for all is the capacity and the ability to share in a bilateral way the expertise of the North and the South to tackle global problems. This is clearly not a new issue. There have been many other reports issued since the original report in 1990. These are just a few of them. Included in this list are two ministerial meetings at Mexico and Bamako, sponsored by WHO, and the report on changing mindsets, which was one of the early ones really generated by Southern researchers saying what they needed in order to be able to develop capacity and take an active role in research, the global research community. In addition to multiple reports, global organizations were created to promote and support research capacity strengthening. The Council on Health Research for Development, you'll hear from later, now merged with the former Global Forum, was created in order to provide direct technical assistance and engagement with countries in developing research systems, and also to keep the issue burning at the global level. And WHO's special program for TDR called Essence has recently been organized in order to try to coordinate the work of donors as they decide what priorities for research investment they should have. The final background statement here is an evolution in the thinking of what a national research system is, one being that we move from really supporting individual investigators to realize the importance of supporting research institutions in which they work, and finally that there need to be national and regional research systems in order to support those institutions and the individuals. So in a sense, one of these elements alone will not really provide the kind of capacity necessary for a country to effectively conduct and disseminate its own research. As we began working on the report, we looked for evidence on successes and challenges, and did identify that many of the issues on the AIDS, TB, and malaria campaigns really had brought the importance of research to the attention of the public and policymakers, so that in some sense the environment was riper for receiving recommendations of the importance of evidence for policymaking, and that there has been good progress in Africa with largely African-led consortia such as the ones that are listed in the boxes there. There also has been engagement of the business community globally, especially in so-called product development partnerships. These are three of the biggest and most visible ones, but at this point in time, about 2/3 of all of the identified drug development projects for neglected diseases are in fact partnerships involving the business community, academia, and others. So what are the remaining challenges? This was the list that we identified in the report. They are reasonably familiar in many of the previous recommendations, in spite of the progress that's been made. Still, a lack of coordination among initiatives, especially from donor countries, concerns that much of the focus of research support is on market-oriented aspects where investments can be returned through marketing, through financial and third-party fees. Often donors leave little infrastructure behind after they've been in a country for a period of time when funding runs out. A lot of the data collected is transferred to the northern partner and often not cycled back or attributed to the southern research partners when publications and ongoing research is generated. It's just a general sense that we haven't seen the growth in the number of researchers or the strength of research institutions that we would like to see in low-income countries. And to some degree, in some countries, it's clearly still a matter of political will and policy support. There are success stories in middle-income countries, such as Brazil, China, and India, but still a series of issues, and I think Dr. Tatanji is going to take those up with you, that remain to be dealt with. And many people do feel quite strongly that weakened research capacity in those countries in which diseases are the most endemic may be one of the major factors in the inability to curb and prevent disease as well as to treat it properly. So with all of this attention and all of these organizations, why would a group of academies feel it was timely to take up this issue now? And the answer really is that our feeling is there are very much more reality behind the notion that global health problems really are shared. If you look at this list, the emerging infections, drug resistance are obviously ones that get a lot of visibility, but climate change is having huge human health effects affecting all countries. Demographic and epidemiologic transitions with the aging of the population and the increase in chronic diseases, these are growing faster actually in low and middle income countries than in high income countries at this point. And urbanization is now over 60% of the world's population live in cities. This number will only increase in the next 20 years, and the growth of cities is also faster in the low and middle income countries. So again, it's no longer just a statement of notional sharing of problems. This really is the need to have a bilateral conversation and collaborations to tackle these shared issues. The academies wish to take them on for a couple of reasons. They are honorific organizations in their countries. The individuals represented there represent the best in science and medicine. They are in a unique position when they work together to influence policymakers with evidence. And we were feeling that if they were activated on this issue, they were also in a position to support those in their countries that are working to promote capacity building. A series of recommendations were made at country level, really calling on member academies to engage with country leadership in an assessment of the status of research capacity building in that country and identify strategies in which they might join to have a particular, to move the issue along, to support priority setting, and also to really promote meaningful and sustained investment in the country, and similarly in the country's requests for international assistance. At the regional and global level, we are calling on member academies to really maintain a focus in this area as they move forward in their regional and global work. There's a lot of attention now on health systems strengthening, and a feeling that the issue of research capacity building, even health services research, needs to be seen as part of that global health system strengthening effort. Ensuring that the issue of long-term national, regional, and global strategies deals with the human, institutional, and systems issues that were identified earlier, and that the definition of health is not only limited to medical care, but also focuses on research dealing with the broader determinants of health. Again, we want to be sure that in our work as the global level of the IAMP network, that we bring this to the attention and the interest of academies into being part of global solutions and supporting efforts that deal with the issue of ethics, fair contracting, and fair credit for collaborations, and you're going to hear a little bit about that. And finally, that we encourage donor countries to include investments in research capacity building as part of their international development assistance. When this statement has been issued, we've been working on dissemination plans, as we often do, press releases, presenting at targeting events such as this. Our academies collaborate in translating the reports into several languages, and then working with our local academies to engage partners at a national and regional level. And we hope that it will be a strong resource for evidence for policymakers going forward. So this is background information, and let me just leave that on the screen as I introduce our speakers. Very briefly, the first speaker will be Professor Vincent Titanji, who is, as you see on the list, Honorary Dean and former Vice Chancellor of the University of Buea in the Cameroon. He is founder and was head of the Biotechnology Center at the university, has a PhD in physiological chemistry, and an expert in protein and chemical reactions, and he's a knight of, he's our only knight, he's our knight, the Knight of the Cameroon Order, National Order, and very important member and participant in many international societies, and has over 100 publications to his credit. Second will be Danny Edwards, who is Council on Health Research for Development, a project officer there. He's from New Zealand, postgraduate work in human bioethics at Monash University, one of the M8 members, and has worked in the WHO and the UK government on issues like genetic testing, intellectual property, and ethics. And finally, Tiki Pang, who is currently a visiting professor at Lee Kuan Yew School of Public Policy at the National University of Singapore, previously Director of Research Policy and Cooperation at the World Health Organization, and Professor of Biomedical Sciences at the University of Malaysia. He's a PhD in immunology, and before moving into policy and management, had over 200 scientific publications in his CV. So we look forward to hearing about the situation in Africa and opportunities from Professor Tatanji. Danny will talk about the sort of level playing field questions that were raised by the report, and finally, Professor Pang giving us a view from Asia and a sense of where WHO is taking this issue forward. So, Vincent, thank you.
Thank you, Madam Professor, for the very kind introduction. I'll start by thanking the organizers for inviting me to this high-profile meeting, which I have, okay, where's the forward?
Now you can use this.
Okay, which I've enjoyed thoroughly. As you can see, the presentation is intended to be complementary to what the chair of our committee, Professor Beaufort, has just presented. Title is a call for action to strengthen health capacity, research capacity in low and middle income countries, challenges and perspectives in sub-Saharan Africa. I will go over some clarifications about definitions. I will talk about the current situation, the challenges, perspectives, and some recommendations before giving a few acknowledgements. As it has been said, there are many definitions of research capacity, but this one is the one that has been adopted by the IAMP for the purpose of this work, and it has just been elaborated upon. Also, research capacity strengthening in countries and the systems involved have been elaborated upon. Health systems can also be variously defined, and these comprise persons, institutions, infrastructure involved in healthcare delivery within a given community. And that's the sense in which I will use it in this presentation. The African health systems cannot be considered as being uniform. In fact, they are at different levels of development in different countries. A country like South Africa and some of those countries north of the Sahara have very rather well advanced health systems. For those in sub-Saharan Africa, many still have generally less well-developed systems, and I will be talking about some of this. The health systems in sub-Saharan Africa can be broadly categorized in two classes. You have the so-called Western or allopathic medical system, which would be composed of the government ministries of health, hospitals, clinics, health centers, dispensaries, with doctors, nurses, midwives, paramedics, and others trained personnel. They may be public or private. And also you have freelance medicine vendors who operate using drugs, some of them fake, from pharmacies. But the other component, which is often not talked about, is the traditional medicine system, or the traditional healers. They are often not regulated, they operate informally, they are neglected, and there's a lot of controversy surrounding their practice, but they are there nevertheless. I would like to say that this component, the traditional medicine component is a major one of the African health system. An estimated 80% of the population in Africa, Asia, and Latin America relies on traditional medicine. About 61% of the 877 small molecules introduced to drug market worldwide during 1981 to 202 is inspired by natural products from, most of them, from plants. And those of us working with malaria know that quinine and artemisinin are derivatives of plant products. In Cameroon, herbal medicine plays a major role in daily health care, including treatment of malaria, other infectious diseases, and even systemic ones. Cameroon, part of the Congo Basin forest, constitutes 20% of the world's tropical forests and 80% of the tropical moist forests in Africa. And from these, at least 500 medicinal plant species have been identified as being part of the pharmacopoeia of traditional medicine. And I can say that just for malaria alone, close to 400 active principles have been isolated and chemically characterized. This information, this means therefore that this part of the health system is not very well regulated, but you can get information from the Ministry of Health or from public administrative officers. There are many limitations associated with traditional medicine as a component of the health system. Although it's widely used and affordable by poor communities of the remote areas, traditional herbal medicines have a number of limitations, which include unpredictable efficacy and safety, non-standardized protocols for preparation and dosage, poor quality control system, and there can be also international intellectual property issues. Now the health system in sub-Saharan Africa, as I had said, contain mostly government ministries of health, individual, for the research systems, they are lodged in government ministry of health. There are also individual researchers in the public and private medical schools who do health research. And there are internationally funded research institutes, for instance, the Pasteur Institute of Dakar, Brazzaville, and other Francophone countries, the Noguchi Medical Research Institute in Ghana, Kenya Medical Research Institute, a state institution, but heavily funded by foreign donors. These are some of the examples of the health research system in these countries of ours. The health research system of Cameroon is fairly well developed and is still developing. The Ministry of Health has a variety of laboratories for quality control of medicines, for authorization of drugs to be imported. The Institute of Medical Research and Medicinal Plant Studies is more than 30 years old and has been focused on public health, epidemiology, and other aspects of health research. And as I said, the faculties of medicine and faculties of science are all engaged in contract research, mostly funded by international organizations like the WHO, the European Union, the Gates Foundation, and others. the Centre Pasteur and the OSIAC, which is a regional laboratory in Cameroon, based in Cameroon, these are mainly concerned with epidemiological surveys. The main constraint that we see at this stage is insufficient networking and collaboration between these units. They may collaborate north-south, but south-south is collaboration, or even among individuals in the same institution, there are constraints there. Now, there are many challenges, and some of them have been elaborated upon by the previous speaker, so I will content myself in mentioning just a few. The lack of a coherent legal framework for coordinating health research is a major challenge. Inadequate infrastructure and specialized laboratories and hospitals have also been mentioned, and that's a reality. Insufficient number of qualified health researchers is still a problem, and insufficient funding and excessive dependence on donor countries and institutions for funding, to me, is still a constraint. Now, traditional healers, by various estimates, provide 60 to 80% of the healthcare needs of the rural communities in Africa. Yet they are either marginalized, stigmatized, or operate outside the system. And there's no research, or very little of the research strengthening capacity goes to their way. Few countries only have legal frameworks for development and mainstreaming of traditional medicine, despite the disproportionately high involvement there in healthcare delivery in Africa. We think that in this case, then, we would make a number of recommendations, some of which may duplicate what has already been said. We think it would be necessary to develop in African countries appropriate legal frameworks for their health research systems, to step up funding for training African health researchers and health service providers, following a consensus and adapted syllabus, I would like to say, to strengthen regional centers of excellence, some of which already exist on the continent, to provide briefs to health policymakers, and to restructure international health assistance to empower our countries to assume responsibility for their own health research, not to the exclusion of international partners, but we should assume more responsibility. Measures also should be put in place in each country to document, validate, regulate, and integrate those traditional medicine practices that are efficacious and safe into the health system, and of course, suppress those that are dangerous, ineffective, or unacceptable. The training of the next generation of African traditional healers and herbalists should be followed up scientifically to preserve this rich African heritage, which is in want of recognition. I want to thank the organizers of the conference for inviting me, the IAMP Secretariat for providing travel support, the institutional supports of the Cameroon Academy of Sciences and the University of Buea are also gratefully acknowledged. And thank you for your kind attention.
Good afternoon, everyone. So first of all, I want to thank Joe Buford in particular and the IAMP more generally for bringing together this panel of speakers and for coordinating the work around the joint call to action on research capacity strengthening in LMICs. Today, I wanted to approach the idea of research capacity strengthening from a slightly different angle, and this is through the lens of research cooperation and contract negotiation capacity. So in a nutshell, we at CoRED believe that there's great potential for boosting sustainable research capacity if the institutions in lower income settings are better capacitated in negotiating the best, fairest outcomes in research collaboration. So this would take us from looking at research capacitation as an act of goodwill to looking at how to get the most out of joint research partnerships and engaging in research collaboration on equal terms. So as Joe noted earlier, one of the recommendations of the IAMP call is that frameworks which support fairer research collaboration and cooperation fairer research contracting are important in building sustainable research capacity. So, as we all know, there are new global health challenges for the 21st century, and that these challenges face all countries: drug-resistant infections, climate change, and NCDs. So we have this massive scope of joint research collaboration based on mutually shared interests. And there's great potential here for low-income country researchers, but also the potential for an opportunity cost if the partnerships engaged in imbalanced, maybe end up being a net financial burden on the LMIC institution. If the researchers engaged in these projects don't have an opportunity for development or recognition through publication, etc. If the opportunities for capacity building are not maximized, and so on. So now that I've set the scene, just a little bit of humor. Contract negotiation isn't easy for anyone. It takes time and it takes skill. And looking at contracting capacity isn't something that we always do when thinking about research capacity building. But the capacity to manage contracts is obviously something large, well-resourced research institutions like the London School take very seriously, and they ensure they have the staff in place to manage them. So the London School of Hygiene and Tropical Medicine has a research operations manager assigned to each faculty. They have research operations contracts officers and finance officers assigned to each faculty. And these staff have specific responsibilities like pre-contract assessment, drafting of contracts, reviewing of contracts, negotiation of contracts, research costing, signing of contracts. But if we contrast that with less resourced settings. So on this slide, we have just collected some anecdotes from the research managers that we at CoRED work with in LMIC organizations. Often there might be, I think as Vincent just noted, there might be no legislative framework in place to provide support. And there might be gaps in institutional policies and procedures, for example, on an issue like research costing. So in contrast with the London School example, here we have often a single person wearing multiple hats doing it all. And many of these people are actually doing a fantastic job. You know, they've learned on the job, they've learned what works and what doesn't. But often they've moved into these positions from being researchers and have little technical or legal know-how in how to negotiate with high-income partners or research sponsors who might be better positioned to influence the outcomes of contract negotiations. Plus, they're trying to do it along with everything else in their day job. A partner that we're working with conducted an assessment of the contracting capacity of 31 partners which they work with across Southeast and Central Asia and the Middle East. They received 21 responses to this. In 70% of cases, the responsibility for drafting, reviewing, and negotiating contracts lay with a scientist or a researcher. And in 85% of those cases, those individuals had no specific form of training in negotiation or in contracting. It was sort of interesting to note from this assessment that the non-lawyers didn't specifically identify any particular issues with the contracts that they had been involved in negotiating. And of course, the lawyers that were questioned were quick to highlight a range of issues. And I mean, this is at least a very crude way of saying that if you don't know what a potential issue is, you aren't going to be able to identify it and flag it up. Non-lawyers noted that they found contractual terms and conditions often unclear or difficult to understand, and tended to end up signing contracts based on trust or long-standing relationships, which of course is important. Trust is important, but it's not everything when you're involved in contracting. There was also an indication of strong internal pressure from the institutions to just sign. So I think it's important to note that the pressure isn't always external. The people involved in signing contracts in LMIC institutions also need to be empowered internally to push back if the contract isn't satisfactory. So why fair research contracting? And there has been previous work conducted addressing unequal partnership issues in research. For example, the Swiss KFPE's 11 Principles of Good Partnership and the Canadian Coalition for Global Health Research's Building Respectful and Collaborative Partnerships for Global Health Research. Now, this approach of setting out principles is extremely important. You know, it sets out the playing field. But it does somewhat rely on the goodwill of the better capacitated partner to play fair and adhere to them. We wanted to approach the issue of contracting capacity from a slightly different angle, to find a way of capacitating the less well-resourced partner to actively negotiate for fairer terms. And the inspiration was taken from a 1992 publication, which the Hesperian Foundation published, Where There Is No Doctor, a village healthcare handbook, which was aimed at putting health knowledge in the hands of low-income communities when there weren't trained health practitioners available. So we wanted to achieve this in the domain of research for health, sort of where there is no lawyer. So where there are insufficient skills, structures and processes to negotiate agreements, our objective was to provide guidance and tools. And this is the backbone of the work that we've been involved in. The Fair Research Contracting Initiative in its current form was inspired really in 2006 when the International Centre for Diarrheal Disease Research, ICDDRB, brought the issue of contracting practice to the attention of the WHO's Advisory Committee on Health Research. They were finding that agreements were becoming increasingly complex and noted that they were often sent to their centre with the expectation that they would be signed with no revision. So CORED was asked to lead an international collaboration on equitable research contracts to look at the issue in more detail and plan a collective response. The end of the first phase of this was publication in the WHO Bulletin in 2009, raising awareness of this issue. So fast forward to October last year, when we had the pleasure of having a meeting at the Bellagio Centre. This Bellagio meeting focused on the structure and the content of negotiation guidance to support LMIC institutions and governments. And it brought together researchers and funders from across the income spectrum. Following this meeting, we formed a consortium of partners who were all interested in pushing the initiative forward. And this consortium includes organizations like BVGH, ICDDRB, the In-Depth Network, the London School of Hygiene and Tropical Medicine, the National Research Foundation in South Africa, Fiocruz, PIPA, Wits University, and WIPO. We have now produced a guidance document, which is a culmination of the work both leading up to and at Bellagio, and we managed to achieve this with financial support from NACAP, the Netherlands African Partnership for Capacity Development. This booklet is basically designed to offer guidance in practical terms of some of the key challenges that were identified in research contracting. And what I want to do now is to sort of very briefly go through these six challenges. So what came up over and over again, first of all, was negotiation, the critical importance of the softer skills of negotiation, which is not something that everyone can easily do. being able to assert your position, to know what it is that you actually bring to the table, what leverage you have, to know where and how to compromise and when. And of course, intellectual property rights, ownership of IP rights often being claimed by the partner who is the better informed negotiator, meaning the less well-informed negotiator might miss out on opportunities for publication, for patents, etc. Data ownership. There's increasingly the expectation that the data and the samples generated within a partnership will be shared. And an issue is the claiming of exclusive data ownership or sample ownership by funders or by high-income partners, even though the data may have been collected by the LMIC institution. So researchers need to consider how to negotiate data ownership, issues such as control, access, storage, management, and use. Capacity building and technology transfer. So the negotiating partner should think through clearly beforehand whether or not the requirements of the project that they're engaging in match their institutional capabilities and methodically identify the gaps, knowing the areas that they would like to build in as capacity requirements. And this issue of compensation for indirect costs. So indirect costs being those costs that partners incur when the research project is housed and conducted within their institution, sort of overheads. So a culture needs to be fostered whereby the real cost of carrying out research activities is mapped out, recognized and negotiated as part of the research contract, avoiding the danger of the project being an overall financial burden to the organization. And the wider legislative context. If you're in a country and you're negotiating a contract where the country does not have an adequate or an appropriate legislative framework in place, you're going to be at a disadvantage. So extra care needs to be taken to note and be aware of relevant international conventions and practices such as identifying dispute resolution mechanisms which are acceptable to you. Also, there's the website. So please visit it, download and continue to comment on the current guidance. It's a continual work in progress. Also come and speak to me afterwards if you'd like. I do have a couple of copies of the book and some memory sticks which I would desperately love to shift. The immediate future of the project, we have just recently secured funding from the Doris Duke Charitable Foundation to take this forward, and what we're going to be focusing on is developing more user-friendly tools for research institutions to use. So converting each of those challenges that I've just laid out into sort of checklists, sort of online resources. And actually what we're really interested in doing is collecting real-life vignettes or case studies which illustrate successful or unsuccessful methods of negotiation. So if you do have stories to share, confidentially of course, again, please see me afterwards. And thanks again for listening.
Thank you very much. Joe's asked me in 10 minutes to cover this small topic on global progress on research capacity strengthening. And as she mentioned, I'm just going to give you a snapshot of the situation in Asia, and then focus a little bit more on the WHO initiative that many of you know about, and to just sort of give you an update of that. So I think there's no doubt that there is progress globally. If you use a proxy measure of health publications per million population, although you see the high-income countries still dominate this upward trend, the upper middle-income countries are certainly pulling in their share, and although the slope is not as steep, lower middle-income and low-income countries are also making progress, however slight that might look on the graph. And it's probably partly due to the fact that if you look at this 2002, we had 1.8 million researchers in the developing countries. It's up to here. In 2007, the red colors here, we are up to 2.7 million. And if you look at the amount that's spent in 2002 up to here, it's about 134 billion. 2007, it's gone up to 272 billion. Figures are a bit old. I'm sure in 2013, this trend probably continues. If you want to pick individual countries in Asia, I'm just picking one here. India is probably one good example of quite tremendous growth in research output, which is, as I said, if you accepted a proxy measure of research capacity. If you take another proxy measure, and I'm taking this from the WHO International Clinical Trial Registry platform, number of trials registered where these countries are countries of recruitment. You can see, in addition to India, China is another Asian country where you've seen a tremendous amount of progress, if you like, in the sense of the amount of clinical trials being conducted. Unfortunately, there are problems. I just want to highlight a few of them. That really, it's not just about size. I mean, if I just use this particular example, China has, let's say, 39,000 researchers, Germany 4,700. Okay, the number of publications, 110,000, 43,000. But these statistics are probably a bit more revealing. The average number of publications per researcher in Germany is 3 times that of China. And importantly, what kind of impact are those publications having? The number of citations, once again, is about threefold higher amongst the German origin of these publications. So size isn't everything. There are other problems. I don't want to associate this with a particular country, but in China particularly, there have been a lot of concern about misconduct, about fraud, about plagiarism, etc. So just quickly, good progress, but I think problems. Continued reliance on foreign funding. Vincent's already mentioned this. A slight skewing in biomedical R&D for specific diseases rather than implementation research to strengthen health systems. Once again, this is probably related to the fact that 70% of foreign funding is going into HIV, AIDS, TB, malaria. Everybody knows that. As I said, concerns about the quality and the fact that a lot of the research is sort of Me Too kind of research rather than original research. I've already mentioned scientific misconduct and the continuing problem of brain drain. So that's just a very quick snapshot of the Asian situation in capacity, research capacity. Joe's asked me to give you a little bit of an update on the WHO initiative, which was seen as a way of perhaps dealing with a lot of these problems that we talked about. Joe already mentioned the global strategy and plan of action on intellectual property, public health, and innovation. That, of course, led to the CEWG, the Consultative Expert Working Group on Research and Development, established by the World Assembly 2010, submitted its report to the 65th Assembly in May 2012. They reviewed a whole range of proposals and came up with a set of recommendations. So these are the recommendations. I just, for the purpose and the context of this particular session, focus on 2 of them. The first one is clearly strengthening research and development capacity and technology transfer is one of the key recommendations. So it fits in very nicely with what the IAMP has been working on. Addressing the capacity needs of academic and public research organizations in developing countries. The next one perhaps is even more important and something that created a lot of excitement. I was still at WHO when this happened, and that is how is this all going to actually happen? Okay, and the excitement was one of the recommendations was the development of a legally binding global instrument for R&D and innovation for health. Now that was a major sort of revolutionary idea because a legally binding instrument at one point was referred to as an R&D, global R&D treaty, which is unprecedented. So the recommendation also said that formal negotiations on an international convention. Remember, we have a few of these legally binding international instruments. The Framework Convention on Tobacco Control is one example. The other one is the International Health Regulations. These are legally binding international instruments that countries sign and are legally obliged to adhere to the various articles. So that created a lot of excitement at the time, because it was a rather revolutionary idea. At the time of that assembly, next steps were identified, and this was a proposal to convene a working group, a technical committee, or even an intergovernmental working group to start preparing for the elements of this draft convention. And then after that, establishing a high-level intergovernmental negotiating body open to all the member states to draft and negotiate this proposed, wide-ranging, legally binding R&D agreement. So that's what was proposed. Did it happen? Unfortunately, no. Immediately after that May 2012 World Health Assembly, it became quite clear that the issue was a lot more complex than initially thought. Many countries began to sort of say, well, maybe we are moving a little bit too fast. So instead of this sort of, working towards actually defining elements of a draft agreement, the proposition was then to say, okay, let's not do this yet, let's just convene what was referred to as an open-ended meeting on follow-up of the CEWG report. And this was convened in November 2012, chaired by John Arne Rottingen. John Arne, are you here? Who is at this meeting, okay? So that was in November 2012, and then in January 2013, the outcomes of that meeting became a resolution at the executive board of the WHO. And those of you who know the process, once it's ratified by the executive board, it went to the World Health Assembly in May of this year. Now, as I said, it contained a whole set of resolutions, but I don't want to go through it. I just want to focus particularly on that one item of the global convention that everybody was getting very excited about. To be very blunt, that idea is basically off the table for now, okay? And basically, this little op-ed in in Lancet summarized it quite nicely. In April 2012, the Consultative Working Group on Research and Development, CEWG, recommended a framework for sustainable financing and coordination implemented through a legally binding convention. However, this week's WHO Executive Board has been asked to endorse a less ambitious plan by member states for a more vaguely defined WHO Observatory on Global Health R&D, which is weak on concrete action despite international consensus that the current R&D model needs revision. Okay, I think that summarizes it quite nicely. I worked for WHO for 13 years, and to be honest, that wasn't a surprising development. So if you go back, the idea now is instead of having a convention, the recommendation is develop a global observatory on global health R&D. So that's the recommendation. And what is that observatory? I don't have time to really go into in detail. I suggest you read John Arne Rottingen's paper on this, where he basically mentioned a few of the functions for such a global health observatory: monitoring, reporting financials, flows, integrating information with product pipelines, providing information for policymakers, funders, et cetera, and importantly, in the context of this session, is providing country support to build capacity in all those dimensions of health research governance. And a few of these other ones have already been mentioned by Joe and by Vincent and other speakers. So in a sense, it does encompass a lot of what the IAMP came up with. Now, I don't work for WHO anymore, so I can perhaps be a little bit provocative. I probably have a lot of questions about this idea of an observatory. For example, who will host it? Will it be WHO? Who will pay for it? In other words, how sustainable will it be? What kind of governance? Which stakeholders will be involved? How will it link, for example, to the IAMP recommendations? How will it link to what Danny described about fair research contracting, et cetera, et cetera? That's all fairly unclear. What is its mandate? What is its legitimacy? What is its ownership? Without sounding in any way self-serving or disloyal to the organization that I worked for 13 years and still very passionately believe in, I am a little bit worried, and John Reeder is here and he can challenge me later, that unfortunately, I think the visibility of research within WHO has gone down a lot in the last 5 years, given as the well-known budget constraints that's resulted in a whole set of reprofiling, reorganization, reduction of key functions around research. But that's just a personal view. So answers to these questions are very easy for me. Go to this session tomorrow, where my ex-colleague, Rob Terry, who's sitting in the second row here, is going to actually discuss what are the challenges in establishing such a global health observatory. So that session is tomorrow. You'll get a lot more information. Thank you.
So thank you very much. We had a very interesting presentation of 4 speakers, and we still have time to discuss what they have presented. So the floor is yours. They're open. Please use the micro and identify yourself where you are from. Is this working?
Thank you. Yeah, my name is Bernard Apia, and I'm a pharmacist and a science journalist from Ghana. I do work for a UK institution that helps researchers in developing countries to publish. It's called the International Network for the Availability of Scientific Publications. And one of the things we have found out is that researchers in developing countries, particularly sub-Saharan Africa, lack the skills and the ability to publish their findings or their research. And when we come, when we are talking about, something like building the research capacity, for instance, I think that publications or communication is should be a big component of the strategy. But I personally haven't seen much about strengthening the capacity of researchers in developing countries to publish by way of training, whether at the academic level or even when they are working as researchers, programs that will really make it possible for them to publish more. So I wanted to find out how that factor into what you've presented. Thank you.
The IAMP has actually been involved in sponsoring programs on scientific writing for about the last 4 years. The National Academy of Sciences in France and the National Academy of Senegal have been collaborating, especially focusing on writing skills for research publications for the non-English speaking young scientists. It's a huge issue in many countries, in many regions. Actually, the focus for this set of meetings has been really in Africa. For Francophone Africans, but there have been some Lusophone, I think, participants in the workshops. And that is now being sort of joined by a modular sort of e-version of similar training developed by the South African Academy of Sciences, which we hope over time between the two can become tools that academies of science and medicine can have available in their own country and make those opportunities available locally for young researchers. But it's a big problem, and we're just touching the tip of the iceberg, but at least the intent is there, and I think the more virtual it can be, the better it will be.
For the nice talks. I have just a quick question for Dr. Titanji. I was curious about what was your thoughts, or what is the directions you are thinking to in terms of regulation of the use of natural products in traditional medicine.
Sorry, what
My question is whether it's about, you said about the regulation of the use of natural products in traditional medicine in Cameroon. I was curious about what's the direction you think that should take on for this issue, that I think is a very relevant issue for countries like Brazil or Cameroon.
Yeah, my comment was really not about regulation pertaining to particular medicines or products and so on. Those are covered by the Convention on Biodiversity. You know you cannot take a patent on a naturally occurring compound. You can take a patent on how it is made, or if you modify it to something more useful, then you can take a patent. That's not where I was hitting. I was saying that the whole area of traditional medicine is ignored, although it exists, and it's running side by side with medicine as you know it. And this comes from the colonial heritage, where they talked about witch doctors, they talked about voodoo, there was a kind of stigmatization. And the whole thing is a mix. There are herbs which have active principles, which actually are active, but there are also processes and procedures which are not, cannot be described as being what you call standard medical practices. And what I was saying is that because this exists, and so many people go to herbalists and healers, it should also be regulated. They should not be allowed to operate, take credit for all that they are doing, which is good, and not be accountable for what they do, which is not right. Allopathic medicine or Western medicine also has this malpractice. People know about malpractice, but people are accountable. They are held accountable because there is some regulation. So my point was about bringing in this. And the WHO has made several studies, several releases, and actually classified it as either traditional medicine or traditional and complementary medicine. But individual countries still have to catch up.
Yeah.
Hello everybody, I'm Dr. Salima Bhatta. I work as a consultant for the National Rural Health Mission in the Ministry of Health and Family Welfare in India. I would like to learn from your experience. The point is that I would want to know, how do you strengthen the bonds between research and policy making? In the sense, has any country set up any kind of institutional mechanisms or some kind of procedures which help the researchers actually feed into policy making?
Yeah, I'll address myself to the last question. During my time at WHO, we realized that that was a very important link that was actually missing. In many ministries of health, policies are made in the absence of any attempt to assess or synthesize existing evidence. So the mechanism that we developed, which has now been put in place in about 25 low and middle income countries, is to establish teams within those countries which are independent of the Ministry of Health, but which bring together local researchers with the capacity to synthesize and present evidence, with the policymakers, and also with civil society. And these teams will then get together and then analyze the problems and work together to try to essentially make better use of evidence for policy. And in our experience, by the way, it's called EVIPNet, Evidence Informed Policy Networks. And in our experience, it works both ways. The researchers must understand that they have to present research in a way that policymakers can understand and appreciate. On the other hand, the policymakers also need help in formulating their policy challenges in a way that can then be addressed by the researchers. So it's been a very productive exercise, and of course, clearly, it depends a lot on the trust. There were many factors and sort of barriers and challenges that we met during implementing this in these 25 countries. But I just want to mention one of them. And that is the reality, and those of you who are researchers, please don't take offense, is the reality that much of the research, even around health systems, health services delivery, is of little relevance to the policymaker. A researcher's mindset is, I want to do research, I'm the best, I'm the professor, I want to do research on this problem. Who the hell cares if it's got any policy implications? Okay, so there is a disconnect. They do research, and the policymakers say, that's no use to me. And I'm reminded of an anecdote, because we had many meetings between researchers and policymakers. Dr. Abu Bakar Sulaiman, who was Director General of Health in Malaysia, we put to him this question: you as a policymaker, how can research be useful to you in making policy? And he gave me an answer that until today I still remember. He said, if your research helps me as a Director General to answer 3 questions, then I will find it useful. What were the 3 questions? Will it work? Can it work? Is it worth it? Okay? So a lot of the research, unless it answers, can it work? Will it work? Is it worth it? The policymakers are not interested. That just gives you one anecdote, but you're right. It's a very real problem. And at the same time, I also sympathize with policymakers. Evidence is only one small element, within what they have to deal with. Sometimes they have to make policy in 48 hours, like what happened with bird flu in Hong Kong. Sometimes there are political pressures, sometimes there are cultural pressures, there are lobby groups, there are, local beliefs, etc., etc. So it's a complex area, but there are many attempts now to try and strengthen that link.
Yeah, I want to speak again to this is a very, I appreciate everything Tiki said. I think is exactly right in terms of the dynamics. A couple of things that I think we have felt at IAMP, that academies of medicine and science would be platforms to play this role. There's been it's part of our own capacity building of academies, because each of the individuals, obviously, that are elected to membership in most of these academies are quite distinguished experts, researchers in their field, in their country, but they have rarely had the experience of working together to really create an evidence base and to then use their influence and their access to make it available to policymakers. So for the last decade, there's been a project in Africa called ASADI. It's now called AMASA, because it's been taken over by these academies of science and medicine in Africa, largely science, which includes medicine, who have really been the beneficiaries and partners with each other in peer learning, but also working with the U.S. Institute of Medicine through a great grant from the Gates Foundation, really, and several things were found. One was the capacity of the Academy, basic administrative, fiscal, and staff capacity to manage things like peer-reviewed studies or workshops or roundtables and get them published and get them into the hands of researchers. And this has been evolving very dramatically over the last 8 or 10 years, so very specific examples starting from different bases. Obviously, the Academy of Sciences in South Africa, ASAF, has always been very sophisticated, but I think happily, sort of midway through this project for them, they published a peer-reviewed study on the issue of nutrition and the immune system in HIV, right at the moment when the South African government was basically denying, if you will, the existence of AIDS, which really blew up the entire theory of the health department. This was quite a courageous thing to do. The health minister, at least, as some of their funding was coming from the Minister of Science and Technology. The Ugandan Academy, which really started almost from zero in this process 6 or 8 years later, issued a similar report on indoor spraying of DDT, which is quite controversial in Uganda, but a very important example in the Nigerian Academy as well on blood quality and the blood safety system in Nigeria. So it's an example of how these institutions have really come together to see the value, I think, of their collective work on the platform of academies. And similarly, one of the things that was recognized was creating their capacity, as Tiki said, to have a conversation with policymakers. So these annual meetings started with policymakers saying, here's what I need from you. And over the last 5 to 7 years, they've developed into actually teams of policymakers and researchers presenting on different issues and how it works. So there's what you might call a demand creation process that has to go on so that policymakers know to ask and know where to go. And I think that's also part of this dynamic, but it's an exciting opportunity for academies.
I just want to add very quickly, to your left there, Professor Nelson Sewankambo, he has also set up a very similar mechanism in Africa called REACH policy. So please speak to him. He'll tell you about this mechanism involving a few African countries to very quickly give policymakers access to evidence and work together. Fantastic example.
Yeah, Edsel Salvania from the Philippines. I just wanted to ask the panel, because part of the problem is, so I'm on a research capacity strengthening committee in the Philippines, and we put out a health research fellowship call for applications and stuff, and nobody applies. So in terms of having the interest, I don't know if the academies are looking at engaging maybe departments of education where you have all these prominent scientists going to the schools and actually drumming up interest in the children, so that at a very early age, when they get to a point where they're thinking about a science career, then they're more inspired and actually apply to these research capacity strengthening as opposed to doing other things.
Dr. Tremulin is being uncharacteristically shy today, or quiet. One of the programs, I mean, obviously the IAMP, because many of you are here under this program, is working on a Young Physician Leaders program, and I think one thing that's been, it's not directly focused on researchers, but it is trying to create the awareness among academies of the importance of bringing younger professionals forward, whether they're researchers, clinicians, or teachers. The IAP and something called the Global Young Academies Program, which is actually based here at the Brandenburg Academy, is really focusing very much on research, and I think really linking, promoting the development of young academies in partnership with academies in countries, as well as the opportunities for advancing global networks of primarily research-oriented young scientists. You should say any more for them?
That's all right. Well, this is the idea to give the young researchers a voice, so that they also can express their experiences which they have in their research life and in universities. And what is quite interesting, if you look into Germany, where we started this 13 years ago, that the impact these young academies has on politics is amazing. Politicians listen quite carefully to what young researchers are saying in Germany. And if you look into the newspapers, there are, I would say, many, responses in newspapers to these young academy activities, because certainly this is the future. And if a professor from a department or a president of a university raises his voice, then he is automatically, actually called as someone who only wants to have more money, wants to have more influence. If the young people are doing it and say we have a situation in our university which has to change, everyone will take it that this is fact. So in other words, it is good if you as a young researcher get up, raise your voice, and try to address topics which are actually of importance to you and to society.
Thank you, everybody, for your presentations, and thank you, Daniel, for that very, I think, very important piece of work that you're working on. I hope I can talk with you a little bit more after. Speaking just on the, my name is Abdullah. I'm from Canada in general surgery, and I do some work with universities and research councils in Kenya and in East Africa. So it seems that while very laudable, the effort by the WHO to try to bring that from the top and from a consensus building, it doesn't seem surprising at all that it didn't go, because it's contrary to everything that the other countries might benefit from an R&D potential difference. And so I wonder whether you do notice a culture change, which seems is what is needed in those countries that might be designated low and middle income, in them standing up and saying that the Kenya Medical Research Institute and other institutes and the academies in particular, do you find a sense that the culture is changing, that they are stepping up and saying, no, we will not take that anymore? And will that be the change that the WHO as a international body can then leverage to implement such a drastic change? Thank you.
It's on? Okay. My name is Maria Bellano. I work on REACT, Action on Antibiotic Resistance, but I have been working the last 12 years at SIDA, the Swedish International Development Cooperation, on research capacity strengthening issues. My question is rather than a question, is like I have been thinking about the CWG and how was the process of votation, whether you were going to have like a convention for research, because in many different countries, the relations with WHO are dealt with by different ministries. For example, in Sweden, the relations with WHO are dealt by the Ministry of Health and Social Affairs, by the Ministry of Foreign Affairs, and by SIDA, that is the aid agency. So when these consultations take place, to which extent in each country the consultations took place in the taking into consideration all the research councils and the view of the researchers, rather than the view of the ministries of health or the aid. I mean, I know that the discussion has been for other countries because similar processes took place. So maybe rather than having a problem with the convention in itself, is the process of making a votation for what is research important and for who is important and who has the voice in different countries.
Just very quickly, the last two questions. Question about culture change and stepping up. I believe the answer is yes. And if I reflect back on the process, and Rob can verify this, the process going through the global strategy plan of action all the way to the CEWG, the developing countries were actually very prominently involved. I can remember very clearly Thailand, South Africa, Kenya, Brazil. In fact, they were leading some of the key working groups. So I think they are, in your words, they are stepping up. Okay, but at the end of the day, you know, to get consensus to really move ahead on this, it's a major hurdle because of very powerful interest, for example, amongst pharmaceutical companies, just to cite one factor. In terms of the research councils, the answer to that is, unfortunately, WHO is constrained by really having to work with ministries of health. And although in the negotiations during the CWG, most ministries of health will bring representatives from the various countries' research councils. But for WHO to work with other ministries, that's very difficult.
Are we okay? Is a special program, so in fact co-hosted also by UNICEF, UNDP and the World Bank. So we're not a World Health Organization department as such, but we work very closely and are on site there. So I'm not going to speak for WHO, but I'll just give you a few of my own opinions on this. The first is just to go back to the last comments about the CWG. I think the thing not to get lost in the debate here is the CWG report was not about all research on all aspects of health for developing countries. The real essence of this was delinking R&D costs from the cost of access within countries. So really, let's not get spinning out to cover everything about R&D about this. And I think it goes back to that fact of what would be an effective funding mechanism that would delink the cost of R&D from the product and therefore increase the access of the people who need it, who have the least money to spend on it from the product. So that's just really a comment to bring that back around to the way. The other one was a little bit about research at WHO. And I can speak for ourselves, and I know that quite a lot of the research done calling itself specifically research departments comes through the special programs and the partnerships. So for example, ourselves, reproductive health, also the Alliance for Health Policy and systems research. Our business is research. But a lot of other research is done at WHO, but it hides away in fragments amongst the different departments. And I think although there are some attempts to bring that together in coordination, and Rob here runs a coordinating committee where we sit together with departments, often as people don't recognize themselves as specifically researchers, it remains fragmented. So this allows me the opportunity to give a plug for tomorrow's session, because this year's World Health Report was in fact research for universal health coverage. And I actually think this is an excellent banner from which WHO research could start to coordinate itself a little, because it is, as you've seen earlier today in one of the keynotes, it was one of the Director General's real key points of an important part of this. And I think it's something we can pull around. For ourselves, its real effect, and I won't preempt what I say tomorrow on a panel, but is to start looking about how we can get research onto the ground in countries. And again, relevant to the rest of the discussion, just a couple of examples here. One of the things that I found quite interesting, we thought perhaps there's a capacity already amongst researchers in countries, and we've seen it grow, and we've seen some of the great achievements of that. But sometimes it's not getting onto the ground to cause a difference in health in their country. We put out a call for grants called impact grants, small grants, $50,000, for researchers to try and get training that allows the research training they've had so far in their career can be reoriented. We thought we'd float this with about maybe a dozen this year. We had 570 applications from 43 countries. This means there are a lot of researchers out there who are not quite able to get their skills into their country, and I think that's something we really need to look at. The other point is one of the other schemes we're looking at the moment is called SORIT, Structured Operational Training, Implementation Research Training. And this is about not creating the researchers, but looking at health workers and seeing what a real asset they could be if they understand how to do some research and can use research along the way. So I think this is a rather broader debate and really essential that we get these things along to the ground.
Tiki, do you want to respond? Okay. Well, I look at our time. I think the time is up. I would like to thank you for coming. Thank you for having an active discussion and all the discussions who took place. And I would like to thank the speaker again, and I will close the session. Thank you very much.